We'll wait for this exciting talk from Dr. Shimizu. Welcome to this meeting. Thank you.
Okay, thank you very much for the very kind introduction, and I'm very happy and pleasure to join this wonderful workshop. So I understand that the participant today is not mainly the doctors, but maybe engineering people or university staff and something like that, and are not familiar with the medicine itself. So first, I'd like to introduce what the telemedicine is. And actually, this field is divided into two. One is the between doctors and patients. So we give the patient the remote examination or sometimes the remote surgery. So we do the surgery for the remote patient, although not so clinical yet. And the second field is the remote communication between doctors and doctors. And this includes the remote consultation from the rural doctors to the specialist in the urban area or something like that. And the last category is the education. And our activity in telemedicine mainly focuses on the last part, education. So my talk today is mainly for the remote medical education. So, and I'd like, my talk today is divided into three. First, background and activities and some Bangladesh situation in the end. So first, the background. So the remote education, as you all are aware, that's very economical and effective. Of course, we can save time and travel expenses, and also we can invite many people at once, and it's quite easy to repeat the education. But in reality, I don't think it's popular in the medical community, and we wonder why not. So let's go back to over 20 years ago when the internet was born in the world. At the beginning, even from the beginning, some people thought and expected to have a remote education through internet, but at the beginning, transmitted images was so poor. So including myself, the doctors and especially the surgeons are not satisfied at all with this remote medical education. And on the other hand, there is the technology called the satellite, and it could send us a very good quality of moving images, but it is quite expensive, so we cannot use it in a daily basis, at least. But I hope you all remember that the Korea-Japan co-hosted World Cup soccer game 2002, and this dramatically changed this situation in telemedicine. Can you guess why? Because these two countries were connected with the big internet in the year of the FIFA World Cup in 2002. And this was a big network revolution. Everything changed in the field of internet. And luckily enough, because our university is located in Fukuoka here, our city was connected to the second largest city in Korea, so the Kyushu University have to play a major role in this big project. So there are actually three technological points. One is that, as I said, we use the big internet. So we used to use the very small internet, so the transmitted images have to be compressed and inevitably degraded in quality. But in contrast, by using the big internet, we don't have to care about the compression at all, and all we have to do is just transmit the original quality. Although it was a very technical challenging, but we conquered it, we solved it, and we had a clear and smooth movie transmission for the first time in this field. And the second point is that we don't have to invest a lot of money on this to start this. So everything is cheap and user-friendly. All you need was just a video camera. You could even find them at office or at home, and a PC with a free software called DVTS. And so, even in the developing country, it is quite easy to join us. And the third point is this internet is not the internet the ordinary people know. It is called Academic Network for Research and Education, and BDREN is one of them. And with these three technical advancements, we could start the very practical telemedicine. So I'd like to introduce you some of our activities so far. Very first event we had was between Korea and Japan. And at that time, the endoscopic gastrectomy, started in, surgery field. And because Japan was the leading country, many Korean doctors visited us for watching our laparoscopic surgery. And one day, the Dr. Yang-woo Kim, seen here in the National Cancer Center in Korea, who was very good at the internet or PC or these kind of things, proposed us to use this big internet for our remote education. So at that time, from our university, we transmitted a live surgery from Japan to Korea. And you see, the Korean side especially, that he was just sitting in his office with a small notebook PC and the 2 monitors. So he could enjoy the endoscopic, not only the endoscopic surgery, but also the OR, operating theater, to see how operator move their hands or what kind of new instrument they use, and etc. And this kind of telemedicine started between Korea and Japan, now expanded all over Asia and beyond. And this Asian Pacific Academic Network connecting Asian Pacific area, and we do have a medical working group in this society. And the Kyushu University is working as a secretariat. So let's pick up one disease all you may know, which is the gastric cancer. Now, Japan and Korea, in these developed countries, it is quite common to make a diagnosis of this cancer at the early stage. So that's why we don't have to need the surgery, but only can treat them with the endoscopy. And the good thing is that they can have a fast recovery with a less cost and back to work early. But in contrast, in developing countries listed here, and I'm sorry, including the Bangladesh, the most often the gastric cancer was diagnosed in the very advanced stage. So that's why we do need the operation for the patients, and they have to be, of course, admitted, and they may fear to have a recurrence, and many people still die due to gastric cancer. So we'd like to emphasize how important to make early detection for this disease, but not only this, And so that's why we started this program between Japan and China many years ago. And, we usually connect our center with the Tokyo, where the pathologist is, with the one in Shanghai, and the other is in Beijing. We can see how it goes. Oh, sorry. Okay.
Intervening part is very narrow, like this, very narrow. But we can't describe precisely because.
So we show them a very good image like this. And then we show the pathology specimen, and also we can move the pathology specimen like this, make it bigger, and we can point out which cell we are really talking about, or something like this. Okay, and then this is for the therapeutic measures. This is what we call the endoscopic submucosal dissection for early gastric cancer. And this event, organized in 2007 was the first time we connected Asia to Europe. So you can see many, many major cities in Asia with Germany for the first time. And we usually make a patient presentation first, and then we go on a live demonstration. So you can see the dark area. This is early gastric cancer, and this you are seeing the stomach, inside the stomach now. And the operator is handling the endoscopy to make a removal of this early gastric cancer in the center. So the procedure is going on, like this. And then at the end, the operator was successful to remove this early gastric cancer. You can see in the center again, okay? And not only we, transmit our advanced medicine, so we learn many things from other centers. This is one example of the bird flu teleconference organized in 2007. At that time, we don't have any patient in Japan, but many in other countries. So that's why we connected and we learned a lot. And now the infectious disease is a global issue, like a dengue, Ebola, MERS. So we use this, system quite often. And as you know, 8 years later, the World Cup between Korea and Japan, the World Cup went to South Africa. Then we another network revolution around that area, so that's why we visited South Africa to organize the system there to start the collaboration. So you can see the quality.
Trying to get all the technical issues sorted out with our IT on main campus, and we're looking forward to the live surgery and just seeing what technical things might occur. But it's fantastic. Thank you.
So I want to express.
So this is our operating theater just in one afternoon, and we ask our technical people to organize this, set up this, and we don't have to pay any money. We never, we don't outsource to make this happen. So just free to do this anytime. And you can imagine the Asia, Japan and South Africa are apart 14,000 kilometers away, but still we can keep this quality. And now FIFA is in Latin America. So another network revolution there. So we are having this kind of teleconference for the gastric cancer regularly. So from 2002, we have expanded our activity like these countries. And now we are collaborating with 57 countries with over 400 institutions, and we have performed over 600 events so far. And I don't think we go on a detail about the technical issues, but what I'd like to say is now the technology developed more. So in addition to the DBTS, which was the very first technology, we have two more systems now, which is much easier and better. And also not only the two-way or multi-directional conference, but also the one-way streaming is quite easy and handy as well. And the time flies, and dramatic changes now happening in the technology. So the DBTS ratio is quite low now, and the new technology like a DBTS, working a lot now. So 10 years ago, we, the REN, Research and Education Network, and DBTS were the must to do this. But now we also have a commercial network in some country, and we use the H53 or video. So the network threshold is decreasing in some countries. So let me tell you some about the Bangladesh situation at the end. The Bangladesh joined our activity as a 42nd country in 3 years ago. And we have connected these 4 institutions so far, and the BSMMU is the best, the most active with the 5 programs so far, and you can see some others. And today, This is the first time for us to be connected to University of Dhaka, and it is our great pleasure to start collaboration with you. And this is some snap worked with Bangladesh, and this is 1 year ago, just 1 year ago, we invited Bangladesh with other countries shown here, and 1 year even before, we invited Indonesia for the endoscopic demonstration with Bangladesh as well. And last year, we had the first telemedicine workshop with the support of TEN, and we had a live surgery from Korea. So, if some of you get interested, we are quite happy. But there are 3 things necessary to start this activity. First, we do need the internet. And I believe that in Bangladesh, still the BDREN is a must. So please talk to the BDREN people if your institutions are well connected. And the second, we need equipment. You know, we don't need actually expensive special equipment. Only the personal computer or some gadget are good enough, so we can talk. And the third one is the engineering support, and this is most important. And cooperation between medical staff and the engineers are the must. So, thank you for your attention, and my conclusion is as follows. First, remote medical education is now possible with low cost and in good quality with the support of engineering support. And the second, there are lots of needs of telemedicine, both domestically and internationally. We can start the remote collaboration based on appropriate needs and good preparations. And at the end of this telemedical session, we will show you surgical video with the new illustration system. Thank you.
Thank you, Professor Shimizu, for the excellent lecture. Some of our colleagues were afraid that whether your details of surgery will be intelligible to the audience today, but you very intelligently customized your lecture according to your audience, and we all enjoyed it. If from the audience anybody wants to interact with Professor Shimizu, we still have some time. So if anybody wants to ask any question or any query, please.
This is Dr. Nayeem from Japan Bangladesh Friendship Hospital. Shimizu Sensei, konnichiwa.
Ohayou gozaimasu.
Ohayou gozaimasu. No, thank you very much. It was a great lecture, and I really appreciate all your efforts from a long time, because I have been seeing you for the last 20 years. You were working with all these things, and you were a great endoscopist and gastroenterologist. And I know the way you are educating people throughout the world, it is a great endeavor and achievement. And thank you very much. I just wanted to thank you. There is no question from my side, but we are really interested to go for this kind of remote education in the field of surgery. As you know, I'm one of the earliest laparoscopic surgeon of Bangladesh, and due to the constraint and due to the limited facilities to move around in the whole country, which was mentioned in your lecture also, domestically also it is very important. Suppose from Dhaka, if we want to interact with the rest of the country, like Chittagong, Sylhet, and many other parts of the country, we can really nicely use this high-speed network for surgical education. And I give a big emphasis on endo-laparoscopic surgery, because here, especially in this surgery, we can transmit the same operation field to the remote areas where the students are sitting. Because, you know, in open surgery, sometimes the cameraman needs to take the view, but in this surgery, automatically the surgeon's view, the surgeon's field, operative field, is possible to transmit anywhere in the world. So I believe the future of this telemedicine for education, especially for education in the field of endo-laparoscopic surgery, is very high, and I really want all your support, and in Bangladesh we want to really make a big network for that. Thank you very much. Shimizu sensei. Hontoni domo arigatou gozaimashita.
Okay, thank you, Dr. Nayeem, and I'm very happy I meet you again, even though it is remotely. And I do hope that you will lead the telemedicine activity in Bangladesh, not only, of course, in the surgery, but also the all variety of the field in medicine. So thank you again, and keep in touch.
Thank you. Anybody else from the audience? Okay, Professor Mir Misbahuddin.
Konnichiwa. Oh, sorry. Ohayou gozaimasu. My name is Misbah from Bangabandhu Sheikh Mujib Medical University. That is, you rightly pointed out about the remote medical education, and you pointed about the cost. And you are working in this field for the last 2 decades. So would you please mention the cost, how much the cost is reduced if you consider with the 20 years back? At present, remote medical education will be possible in low cost. So how much the cost is reduced? That is my question.
Okay, thank you, Professor Misbahuddin. I'm very happy to see you again too. So you asked about the cost, and you know, this slide may tell you some answers, you know, but the thing is that from the very beginning we are quite keen on the cost. So we didn't and don't want to use any costly equipment because we cannot. It is hard to expand these activities to the developing countries where the remote medical needs is really are. So, for example, DBTS, to do the DBTS, we don't need any special equipment but PC. But the disadvantage was a big network. So some hospital have to pay some money to have a sufficient amount of the network. That was the situation with the DBTS. And H323, it's much easier, and we don't have to pay a big money for the network, but instead, to use the H323, the hospital have to be equipped with this special equipment, which is usually costly. And as a third solution with video, you know, we don't need a big network, and satellite station do not have to invest any money. As far as we, TEMDEC, Kyushu University, has a server. So we can provide them an ID and all the technical details. So the remote station have to prepare only PC and nothing else. So I would say that the video may be cheapest, but again, you know, all these systems may be good enough to start this activity, you know, without any special investment, except the H3, I would say them. That's all.
Dr. Shimizu, thank you very much. Let me introduce first. I am Professor Dr. Azad. I am the Additional Director General of the Ministry of Health and Family Welfare. So I did not actually enjoy the full piece of your lecture, but maybe 2/3 of your lecture I have enjoyed here. And as Professor Dr. Liaquat said, really all the audiences present here, they have actually enjoyed your excellent lecture. But I am representing government, so on behalf of the government, I have something to share with you and also something to actually learn from you. So first of all, this is very unfortunate that we work, although in a country, but we work in a disjointed environment. I think you have visited Bangladesh, and many of the audiences present here, probably they do not know, and you do not know, that the government has got quite a number of centers which can provide telemedicines. But in Bangladesh, actually, given the situation that we need to have a referral from the remote centers with the specialist center, we have created this center. So as of now, we have got 43 centers, and we are expanding maybe by this financial year to 95 centers. But we have actually created this environment or these facilities for mainly providing the healthcare referral services to the patients visiting the remote centers. And I think for obvious reasons, we could not expand the education using this setup. But in your presentation, you have mentioned that you have an organization, it is called Research and Education Network. And I am interested to know how this Research and Education Network actually can help the government so that we can utilize the existing system, because we have already 43 centers and we can use it for actual medical educations. But the teachers in the medicine in Bangladesh should also should be interested to also, I think, use this kind of environment. So I shall request you, probably you can send one representative, or by yourself you can visit Bangladesh and you can talk to us so that we can extend our collaboration beyond to the BDREN as well, so that in addition to the healthcare, we can also expand to the utilizations of the same network for actual research and education in medicine in Bangladesh. So I am looking forward for your response.
Okay, so thank you very much for your question. And actually, our role is not only education, but to take advantage of this network for the patient care, the health care. So I don't know the network situation in your country for details, but network is network. I mean, the internet is the internet. So as far as you can use the BDREN for the clinics, and the BDREN can support the clinics for the internet, field. I believe that you can use this telemedicine for the patient care in Bangladesh. And the second is that the one team in our own Kyushu University have a good collaboration with the Bangladesh hospitals, and they are having a remote healthcare for years. So we do know the remote healthcare is working in Bangladesh already, and we are more than happy to continue and expand this activity as well. So please do keep in touch and expand not only education but also the healthcare issues in Bangladesh together.
So actually, to inform you, these 43 centers I have mentioned, and I have also mentioned that very rapidly we are expanding to 95 centers. These centers have actually very high bandwidths, very dedicated bandwidths, and we have got all the peripherals required for telemedicine consultations. So these are the advantages, but many of us, we do not know. So we should actually utilize further these kind of opportunities already existing in the country.
So one more information for you is that we, as a APEM Medical Working Group, now we are organizing a domestic engineering teams in each country so that they can talk more and to expand this to the hospital or the medical colleges, because not all the engineers can speak good English, and they know more about their own domestic country. So if possible, I would like to make a team in Bangladesh inviting an engineer from all these 43 hospitals or 90 hospitals at the end, as you mentioned, to train them and educate them to be able to support the telemedicine for the doctors.
Sorry. I want to just let you know the status of research and education network in Bangladesh, because we need to communicate among ourselves to understand what we have done until now. Shimizu talked about the research and education, and this is a dedicated network, you know. And the present session taking place with the help of Trans-Eurasia Information Network, and with which BDREN has established its connectivity since 2012. And by now, the BDREN has been able to connect 35 universities, mostly public universities, including just one private university. It is North-South University. And the BDREN is going to connect 12 medical colleges and then 10 research institutions. So at the end of the day, BDREN will keep on connecting all the institutions in Bangladesh. And about the centers that you have said, that there have 45 centers have been established until now, and by the end of the year, you are expecting that this may go up to 95. So all these facilities, I understand, is being connected with the commercial internet, commodity internet, but for this kind of session and telemedicine session, it requires the dedicated connectivity like Bangladesh Research and Education Network, BDREN. I think this is just to let you know about the status of BDREN.
Okay, thank you very much. You know, that's what I imagined. So, and that's often the case in other countries. So that's the matter of your local issue. So I think BDREN and the government or the Department of Healthcare have to talk together, or the healthcare government department have to improve the network good enough for the remote consultation. So, I do understand that there is still the problem and the issues to be considered and discussed altogether. Thank you very much for your information.
Yeah, Professor Shimizu, I just want to add one information. You have been informed by Professor Azad that there are 43 centers in government sector, in clinics or hospitals for telemedicine purpose. So you can probably you have already seen that there was one screen, Chowdhury Upazila. This center is one of the 43 centers. We have already connected one as sample basis, and Professor Azad will show how the facilities are being used for telemedicine purpose. Thank you, and thank you for your presentation.
Okay, thank you very much. So the one more comment is that the network is everything. If the network, you don't have a network, we cannot do anything. And if the network is poor, the quality is poor. And if the network is good enough, that we can do the good enough education in quality and good enough consultation with good images. So the internet is everything. Internet quality is everything. Yeah, thank you very much.
Thank you, Professor Shimizu. I think one of the purpose of this kind of workshop is to bring the stakeholders together. And I think this purpose has been served in this morning very well, because many people do not know each other and what they're doing. So Professor Azad is a great enthusiast from the government sector. He has been serving in this field for a long time. At the same time, Professor Akhtar Hussain is a great enthusiast from the UGC. And there are clinicians, there are technologists here, other scientists and policymakers. So I think this will go forward, and of course the ideal thing would be to link government facilities with private and other public private initiatives. So we would like to thank you again for this excellent talk, and the audience enjoyed it very much. Thank you very much. Dear audience, the next presentation is by myself. It is difficult to introduce oneself. I'm by training a medical doctor, then got my master's in medical biochemistry and a PhD in medical cell biology. And due to certain social commitment, I also got involved in public health issues. And now I'm the, I served for a long time in BUHS, about 23 years as the professor of biochemistry, cell biology, and also head of research. But later we founded the Bangladesh Institute of Health Sciences, and now I am the founding Vice-Chancellor of the Bangladesh University of Health Sciences. In my life, I tried to get involved into research, and we have achieved modest success and acknowledged by some, like Islamic World Academy of Sciences or by the government, the Prime Minister's Gold Medal. Today, I'd like to especially mention that we created the first Department of Health Informatics in this region, in fact, by the help of Rockefeller Foundation, where people like Professor Azad and others got involved, and here other people are, my colleagues are here. And this, through this department, we are trying to train people in master's level people from many sectors. Some are from also from Bangladesh Army, some people are here. Anyway, I would like to present telemedicine in a different context in health education and health promotion. Well, you can see the topic is telemedicine in health education and health promotion. Sure. Okay, as you have already heard, and you know that telemedicine has made phenomenal progress in some branches of medical sciences. To cite go to a little bit different discussion, because the solution of any healthcare problem is based on the epidemiological and other facts, and also the burden of diseases. If you look at the burden of diseases, we get a very, changing picture in this world, because the more than 60% of burden of diseases, even in a developing country like Bangladesh, is due to non-communicable diseases. We are going through a pandemic, and it is going very fast. So in this particular case, it's not a curative care, but prevention. We have always heard that prevention is better than cure, but in fact, we should change this proverb to prevention must be prior to cure. It's not a better, it is a priority. And when we go for priority, it's community awareness, participation, and leadership is at the center of NCD strategy. Because you can eradicate mosquito and mosquito-borne diseases by some central intervention, but you cannot change the food habit of the people. You cannot change his smoking habit, or you cannot change his lifestyle, exercise, and other habits just by compulsion or by central, decree. It is the awareness of every person and the participation and also the local leadership which is at the center. As you know, that we have highly disproportionate investment in curative care. all investments are going to tertiary hospitals if we really analyze most of them. And also it is linked that in central facilities compared to peripheral facilities. So in this case, we have to look at this telemedicine aspect, technology aspects, from really pro-people perspective. And that's where how we can use telehealth rather than just merely telemedicine, because it is not medicine, it is health which is our concern. It's not working. Okay. So, in this particular case, in fact, our proposition should be, we always think technology as just a technological development, because we witnessed fantastic development already in the last few decades by Professor Shimizu. But in our case, it should be looked at as a paradigm shift in healthcare, because how it is helping in the changing health situation. The most important the most important part is the community empowerment, because we have always dreamed in healthcare that people in a democratic society will take care of their own health. But if we look behind, we are always captive of the health by the healthcare providers. And this technology can really empower community in a true sense, because that can, give him the power to choose by getting proper information and also choosing his own life. This can revolutionize, of course, chronic care, because compared to others, if you have, for example, electronic health records, if you have information, if you have the whole, life, because these diseases are lifestyle diseases, are chronic diseases, lifelong diseases. So it's not a one-shot issue, and telemedicine or telehealth can really change the chronic care situation for lifelong. It can give excellent biosurveillance facilities or opportunities, and that also empowers the policymakers and interaction with the planners and executors to really go forward with a healthcare program. And I think we all, when we talk telemedicine, we give the most importance to electronic health record. Yes, this is very basic, but this is only a tool to really, in fact, go for care, and particularly for consumer and empowerment. Now, we can have lots of services in this respect. We know that we can have specialist referral services. Professor Azad already told that we are using very little of the facility which we already have, because still we really don't have any program to empower people to go for these referral services. The services can be directly patient care, as you have seen that, yes, a remote operation can be done, a remote training can be done, a lot of direct patient care can be mobilized through this technology. And also, not only one-shot care, as we said, that most of these diseases are lifelong diseases, so you need a monitoring, and that monitoring can be done remotely. So also the medical education and mentoring, as we have already heard, that is one of the purpose of today's workshop. And yes, the medical education can be provided, but this education should not be limited only to high-tech educations or only to some of the surgical or other maneuvers, but also for simpler public health promotive educations. And these services can give consumer medical and health information, and that is at the root of community participation leadership. And this is the most neglected area, that consumers are not getting enough medical and health information. They are ignorant, and sometimes the providers exploit them because of these kind of gaps. So in this particular case, we have to use this technology for this kind of information sharing. Now, we may have a number of technical approaches. We should not forget simpler techniques like, say, SMS-based M-health approaches, because we are always going for higher and higher technology, but there are simpler technologies which can have one-way or two-way communications. In one way, we just send messages passively, but in two-way, we can interact with a very simple message, and people can ask in a center who can really respond to the need of the individuals. We can go for the higher-end handheld devices because those are getting cheaper and cheaper, and we are having 3G or 4G communications where some video education is possible at the remotest level, and that should be also explored. And there are, of course, opportunities for large-scale ICT-based approaches like video conferencing, trainings in the periphery. And another important thing is the integration of the traditional mass media campaigns with latest information, health information technology-based approaches, because we are spending millions and billions for traditional approaches like billboards and other leaflets, and also in the mass media and newspapers, advertisements, how we can really integrate with the modern technologies. That is an area which has to be solved in a contextual basis. Now, the target groups need to be defined because we sometimes use contents very blindly. Unless we define target groups, actually those contents may not be really specific and may not be communicating properly. So it can be for general people, but there are now opportunities to target specific groups. If some people are waiting in a cancer center, then message can be customized for those groups, because in this case, in Bangladesh, not only patients, usually relatives and friends comes with the patients. And we have in BUHS a lot of experience on that when we give education, from the Professor Ibrahim's time, the education is not only meant for the diabetic patients, but their relatives and friends, and that is very effective in really combating diabetes. So this type of contents can be edited and customized for each group of target audience. We should also customize contents for healthcare providers, and this is not only for specialists but up to the community level workers. And this is very important that opinion leaders, school teachers, or say union council members or local elites, many people should be motivated for this kind of those contents can be delivered to them according to the audience. And also there are administrators. For example, when we are going to in a nationwide campaign, we went to Sylhet, for example, for a GDM campaign, gestational diabetes mellitus, and then one in a DC office, on Superintendent of Police said, "What is my role? Why did you call me?" We said, "Okay, if I say that a pregnant mother should walk in a park because it is very healthy for her child, and if she wants to walk in a footpath, unless you provide her security, unless you can really take out hawkers from the footpath, how can really she work?" So you see, messages should be customized for every people, because the NCDs and modern health problems are for every people, and it is multi-sectorial. And then policymakers and planners should be involved in this kind of education. We of course face challenges. These are general challenges of telemedicine, interoperability or standardization. These are general challenges which has to be solved, because one NGO or one say government agency may develop one type of program, another may develop another type of program, and if there is no standardization and interoperability, then there are duplications, contradictions, etc. So not only in telemedicine, but in telehealth also, we need to define certain standardization where people can really cross-talk with each other, and the program may be more efficient and coordinated. And then there are problems because in this case, we have tried to import, say, from American Diabetic Association, a lot of resources. This is easier to import because we just download, many are free. So there is a temptation that we always copy them and then start broadcasting or publicizing in our community. So this is not an universal issue. There are special issues. For example, if we want to promote a food and we promote a say European food in our community for weight loss, that may be even counterproductive. So we have to really go for customization based on socio-cultural and economic context of the country. Then there are certain concerns because these two are related. There is, of course, a tendency to overindulgence to technology. We all know the Facebook story, or we all know the social media story, that people thought that these social media will increase human interaction. In fact, a lot of research has proved that this is increasing rather isolation, mental illness, and in children that is also leading, and young adults leading to physical illness. So we must be very careful that this is not a one-way sword, it's a two-way sword. So we have to be careful that we should not ignore human factors when we are using technology for public health education and promotion. That's why there are certain issues which has to be taken, and we should not go for premature switching to always newer techniques. We have to really switch and integrate traditional values and other things, and we should not spend too much on this kind of technology unless we are pretty sure what really we are going to achieve and how we are going to create a balance. So this needs really evidence. I think this is the least important part of any program in our country, and in fact we also were responsible for such things. In fact, we introduced one of the first telemedicine program already a decade back. We created a node from Dhaka in Burdem and then in Faridpur, and we ran it for a few years with the support of Grameen Telecom. And probably I don't know whether Dr. Nayeem had any session in that program, because we started those sessions. And I regret that we did not introduce any impact assessment program, operational research for that. We run one of the most efficient, I don't know whether it is really effective, but at least in number wise, the Diabetic Association runs a program for the diabetes doctors. It is a distance learning program, but so far I don't know whether any study has been done on assessment. So the same things. I think most of the cases we don't run really any operational research. We need that, and the probable areas can be, for example, socio-cultural and technical preparedness, whether the society is prepared for certain kind of techniques, and also for effectiveness, and also for short and long-term impact. And very importantly, we have to really go for economic analysis, and all these studies, I think we can design preferably randomized trials, and randomized trials can be designed in a community setting. At least cluster randomized trials can be designed. So I think these are very important issues when we are running any program for this kind of telehealth. So with this, I would like to conclude that it is high time to promote the idea of telehealth in the overall context of the philosophy of healthcare, because telemedicine should be a component of telehealth. It is health which should be our concern, and in the health we should also we should not carried away all the time by the investment of on curative cares. Promotive care is the very important part, and let us promote the idea of telehealth. And with this, I'd like to thank you for your kind listening. Thank you very much. Well, if somebody feels If somebody feels, yeah, that would be.
Actually, Professor Liaquat mentioned the term. I would like to say something about the nomenclature. Nomenclature sometimes confused. For example, the telemedicine, telehealth, that is appropriately you placed. And why not e-health?
Yeah, I think rather than tele, it looks smarter, at least. If you ask me as a, aesthetically, e-health is smarter. And that explains. Yeah, we can do that. We can do that. So we should,
Thank you, Professor Liaquat. It was a very, very informative lecture. And actually, what I was telling, that this nomenclature, you just raised a very important point. Because Dr. Kalam Chowdhury was telling me this morning that he asked some of the surgeons to come. When they heard it is just a conference on telemedicine, so they were reluctant. So I don't know even how to popularize this thing. The surgery is a very integrated part of this research and education network, because we really can do a lot of work through this high-speed network. And I don't know how to make the surgeons interested in it, because whenever we call them, please come here, we are talking on telemedicine for research and network and education, they are not understanding it. The telemedicine is still now for education or for training. We really couldn't make it popular. We have been also working on it for a long time. So we'll have to work on it. I'm not sure. I'm not asking you to answer it right now. But what I believe, everybody involved in this high-speed networking for research and education, we should really come up with some concrete things which can attract people to come and join us for research and education. And at the same time, what I'm seeing that Kathmandu Model Hospital is there also. So we should also ask them, are you hearing us, Kathmandu Model Hospital?
Yes, we are hearing you very well.
Yeah,
and
thank you very much.
So
Thank
you
you
are
very
not
much.
participating.
I'm sorry.
You are not participating.
Yeah, I'm sorry that.
No, I'm not there. I am not there physically, but I am very much with you.
Oh, thank
this
you
is
very
Saroz
much.
Dhital, and
so actually,
I am seeing, some of my old friends there also. So very quickly, because we don't have enough time, I am very much interested in the discussions that's happening right now. One is about the terminology, that is telehealth and telemedicine and e-health. Here, what we believe is that e-health is a relatively big topic, because health is not just treatment of the body, and we have to go beyond that. And many of you have already told that whenever we are talking about community medicine, public health, or the expanded understanding of the health, then e-health is the proper term. When it comes to the clinical intervention, then it becomes medicine, and therefore it is telemedicine, including telesurgery and all these things. That's one point. And another, nasty comment I want to make is that somehow, fortunately or unfortunately, wherever I go, I find it is the surgeons who are most interested in telemedicine. Thank you.
especially the endo-laparoscopic surgeons, they can really do a lot of work for training purposes with the help of this high-speed network. And would you please introduce yourself from Nepal?
Oh, I am Dr. Saroz Dhital. I don't know how else I should introduce myself. I am a surgeon who is always wanting to retire a little earlier, but somehow engaged in one or two activities. I am also now supervising some, FCPS students. Unfortunately, not from Bangladesh. We have got a special, relation with CPSP, Pakistan.
Yeah, the Pakistan.
And I'm also supervising, other postgraduate students. And our institution has been involved in telemedicine activities or e-health activities or e-health education activities for the last 8 years or so, immediately after we regained our democracy or we became republic. I think that's all. And all around me, they are wonderful people, Dr. Uday, Dr. Urban, they are the people who do the real work. And I am here only to talk. And these engineers, without them, I would have done nothing. Thank you.
Of course, engineers has a very, very important part, what Dr. Shimizu also mentioned. We should have a networking between ourselves and cooperation with each other to develop this telemedicine for research and education, I believe. Thank you, Sharoj. And please do participate in our discussions.
Again, just 2 minutes to share with you.
Of course.
There has been lots and lots of this stress on the technology. With whatever experience we have so far, I warn you that without people getting interested in telemedicine activities, any kind of, any high-end technology isn't going to work. So you have already, started noting that on the people who are in the remote area, they are working hard, but working hard is one thing and getting interested in telemedicine activities is totally another thing. There are, so many things, so many psychological things to be concerned about. I hope that, since we are close neighbors, we will be sharing these things in the future.
Yeah, definitely. Thank you.
Yeah.
Thank you very much. We'll have to keep in touch and work for each other. So, anything from Kyushu? Kyudai kara nani ka hanashi shimasu ka? Kyushu Daigaku? Kikoemasu ka?
いや、聞こえます。There is no comment from Kyushu University.
No comment from
Okay.
Kyushu University? So Shimizu Sensei is busy and he went for surgery.
Yeah, he gone, but
I understand.
we are
But
ready for the...
we are eagerly waiting for Otsuka Sensei's surgery.
Yeah.
He will be doing that pancreatic duodenectomy.
Yeah, just
Yes.
come here now and we are ready for the session. Thank you.
Thank you very much.
Okay, thank you, Dr. Nayeem, and thank you, Dr. Sharoj, and all the colleagues in Nepal. And Dr. Sharoj, you had very valuable comments. We'll continue our talk on terminology later, and I think the most important part is to really go forward with some commitment. Many of the stakeholders are here, and we'll go forward. Once we really get the minimum level of manpower, that is the very important part. Yes, somebody, you want to ask something?
Sir, I would like to mention some limitation of the network provider, because we are working in the operation theater, and I am from Bangabandhu Medical University, and so far I know that this network service is in a center like the virtual library or in a center. But if we share it, we would like to get it in the operation theater so that we can use this network for surgical education, and I think this is very essential things. And for the last few months, we are trying to get it in the operation theater, but still it's not possible to get this service.
No, these are the challenges. Service. I think as Dr. Shimizu said, that last line is very important. He said the engineers and correct people who can really understand and handle it, and also the technology support. So I think these are the issues which have to be solved. We should move forward to the next speaker because time is running fast. And we would like to introduce, well, Professor Mir Misbahuddin is very well known, and he is also a medical graduate. He did his PhD in 1988 from the University of Tokushima School of Medicine, Japan. So this workshop is dominated by experts from Japan or Japanese trained. He served in the IPGMR, and then he is the professor of pharmacology in the BSMMU from 2001. And he has many research interests, but arsenicosis is one of his primary area. And he is very active in the editorial board of the pharmacology. He is the editor. He was also in Bangla BMRC Bulletin editor, Pharmacology and Physiology Journal editor, and also in the Teachers Association. And he is interested in asynchronous and synchronous virtual pharmacology. So with this introduction, I would like to invite Professor Mir Misbahuddin on his topic, home-based e-learning for postgraduate medical students. Professor Mir Misbahuddin, please.
Thank you very much. Thank you very much. I'd like to speak something about my experience in e-learning program from 2010 to 2016. From where I started. It was 2010 when I thought that I should start e-learning program. Then I thought the next issue is in which subject. I decided as a pharmacologist that pharmacology will be the priority. Then what about the undergraduate and postgraduate students? I thought that the undergraduate students, a large number of people are getting admission into our medical colleges, around 9,000. And in most of the medical colleges, there are shortage of teachers. And required teaching is an important factor. That is why I preferred to start e-learning program on for undergraduate students, and it must be asynchronous. Because previously I thought that all the teachers will participate and make the teaching materials, and then it will be uploaded. And on that basis, I wrote a protocol and submitted to the UGC, University Grant Commission, and subsequently awarded the grant. And then subsequently, I worked for 3 years, starting from 2011. And the first thing was to make or build awareness among the teachers as well as students. I arranged several workshops for the teachers, and in addition, I visited 16 medical colleges to make awareness among the students. And subsequently, I customized the e-learning management software that is well known to all, the Moodle. We customized with the help of the professional people. And the third step was to make teaching material. That is the very hard part, difficult part of this component, because I did not want to just digitalize the present teaching materials, because this type of teaching materials is not so effective. So we followed the Bloom's taxonomy based on not only the knowledge, understanding, application, then analytical creating. On that basis, we started, and we also considered about the curriculum. And then we uploaded the contents, and we subsequently found that this type of asynchronous teaching is not so effective. And with the help of Professor Akhtar Hussain, I then shifted my idea from asynchronous teaching to synchronous teaching. And it was 2014 we started synchronous teaching, and that is why I visited 32 medical colleges, and there was an arrangement of lectures, and in 1 year 84 lectures were conducted from BSMMU to peripheral medical colleges. And the response from the teacher is good in delivering the lecture. And we use various video conferencing softwares, including starting from the Skype to VCMate or GoToMeeting or TeamViewer. And we use different modems, different internet modems with different speeds. So which one to find out which one is the best, which one is the best, which one is the best. But here also I have found some difficulties. Difficulties because when I wanted to take more than 2 institutes, so in that case it is very difficult. The current software is not suitable. And in the periphery, the internet speed is low, and the sound system is also the problem. In the peripheral medical colleges, they just think that the classroom means a space with some sitting arrangement without considering the sound. And it is also expensive because when I conducted my class with the peripheral medical college, I had to send the engineer as well as equipments, modems, and in addition, I had to pay remuneration to the teacher. But even then, I was dissatisfied because the teacher's cooperation is not so that is I did not get, because their philosophy is that the student may compare his lecture with the lecture from BSMMU or some other teachers from BSMMU like this. That is why there is a real problem I faced. Subsequently, I shifted from the asynchronous to synchronous, then home-based. And now I fully satisfied. That is why this is for the first time I am presenting this one, and I also enjoy it. And I shifted from the undergraduate medical students to postgraduate medical students. And now I am using the technique by which the unlimited number of students from anywhere can see or read or observe anything, learn by this technique. There is no question of internet speed and good quality picture and sound, no problem. And students stay at home. And recently, it depends upon the time to time. Nowadays, I am taking regularly 2 classes on Sunday and Thursday, around 7 to 8 p.m. I selected that time. During that time, the number of users is very low. That is why I can get the higher speed. And the lecture, 1 hour lecture, in that case, the 10 minutes is for setting, and 40 minutes for main class lecture, and 10 minutes for question session. And it is one-way streaming. And here, student does not pay any money, or just internet, smartphone, laptop, and desktop. Desktop nowadays are not using. Laptop, okay, and smartphone, even the smartphone, but smartphone has one problem is that it is not documented, recorded in the screen. Otherwise, he can learn everything. He can learn or he can see the presentation. Internet connection, modern, broadband, everything we know, and headphone. When the student sit in front of the computer with a headphone, clearly hear the lecture, and he becomes excited. So really, student and I enjoy this. And there is this in 2015 and till today, the student just opened the YouTube and entered my name, live streaming, and then everything okay. There is no question of no problem. Just one-way streaming. And the student ask the question at the end of the lecture by chat. And the recorded video are available in the YouTube until the next class. That is, the student can repeat it. That is the one advantage. And I asked the student in the next morning, because I have students, around 20 students in my department, and the next following day, I asked the student what you learned. So that is face-to-face and solve their problems in addition. Now I would like to show some screenshots This is the software I use that is free of cost. This is the screen. This is the screen I first set it. I have started the class just with a headphone. That is just like I am just like a pilot in a aeroplane cockpit. And here you can see that my face is there, and at the same time in the left side the presentation is also there, so I can discuss. And here only the presentation. And here you see all the students. At first I say to the students that introduce yourself. So everybody say hello sir, assalamu alaikum, or something like that, so I can understand who are the present. And there the number is there 12 present at that time. The 12 is there. And this is the statistics. And the upper border is the presence and is the question. And the next morning, I asked the student to attend class that is face-to-face. And this is the picture of the students. Then I asked one of them to take the class as a teacher, and others are as students. So they also enjoy it. This is important for me. That is, by this process, the student learns how to teach his or her student in future in virtual environment, because they must learn. Because nowadays I have found that the 80% of the student, medical student, can use the smartphone or computer, and 80% of the teachers cannot. That is the problem. I'd like to quote the quote Bill Gates, one of the important messages. Technology is just a tool. In terms of getting the kids working together and motivating them, the teacher is the most important. Thank you very much.
I think there is a technical name the way you are teaching. They call it a flip model or the reverse model. So in this model, actually, what happens that you take the class outside of the classroom, that what you are doing, and in the class you interact through some activities, like you are taking the students that okay, you conduct the class. So you are actually you are actually doing the things opposite way. So in classical flip model, the way the things are running now, that in the classroom you give them the homework, in the home you give them the classwork. So you give them the videos, or in this case you are actually taking the class. So you are taking the class at home, and in the class you give them the activities, homework or set of problems and something like that. So my question is that why you are not giving them the just videos? Why you are taking real-time class? Did you get my question?
The last word?
Why you are not giving the videos? Because you have already recorded your videos. So for example, in your case you have 20 students, right? So if it is a just 1 year course, you have all the videos of that particular course for 1 year. So you can just circulate those videos for the next year students. Will you do that, or you?
Actually, video has one disadvantage. That is, once it is videoed, it will not be changed. That is one. Because science is dynamic. It is everything changes. That is, I think. And another thing I'd like to say, that the definition of teacher is changing. Because the Google is a good teacher. You can get a lot of information. But the experience, we the teacher should just guide as a supervisor or mentor or something like that. Professor Ali can say better. So we have to, if I see anything, 20%, 10% maybe. If I hear anything, I can get 10%. I can learn 10%. If I see, 20%. If I engage, 90%. So you have to think which one is the best.
Otherwise, we will have to move because we have a little change in the program. Our friend from Japan, Dr. Takao Otsuka, he has a class to take, so we will little bit reverse the program. Dr. Naeem's lecture will be later. But Saturya people, are you there?
Yes.
Okay. Do you want to ask anything? Otherwise, we will move to Dr. Takao Otsuka. Unfortunately, we don't have any CV, short bio from you, but maybe you can kindly introduce yourself with a few words. And we would like to welcome Dr. Otsuka for your presentation. Thank you.
Thank you very much. I'm Takao Otsuka. I'm surgeon at the Kyushu University, and I am major in the hepatobiliary and pancreatic surgery. So today's topic is superior mesenteric artery first approach during pancreatoduodenectomy. これ、動画用か。失礼しました。The concept of the SMA first approach is to reduce the intraoperative bleeding. And if the portal vein first approach may increase the intraoperative bleeding due to congestion, so the SMA first approach may reduce the bleeding because of the congestion. There are several types of SMA first approach. And the most standard method is inferior suprachoric approach, namely the anterior approach. Another major approach is inferior infrachoric approach, namely the mesenteric approach. Today we showed this anterior approach. Another issue is the range of the lymph node dissection along the superior mesenteric artery. According to the Japanese Pancreatic Society Pancreatic Cancer Classification, number 14 along SMA, lymph node along the SMA is range from origin of the SMA to origin of middle choric artery. And the origin of middle choric artery is usually consistent with the confluence of superior mesenteric vein and first jejunal vein. And inferior pancreatoduodenal artery is usually located between the origin of superior mesenteric artery and first jejunal vein. We usually use the anterior approach with first jejunal vein oriented method. See this figure. Here is the first jejunal vein, and here is the superior splenic vein. The origin of the superior mesenteric artery usually located behind the superior splenic vein. So usually we can identify the inferior pancreatoduodenal artery (IPDA) between superior splenic vein and first jejunal vein. This is a retrospective data of the comparison of the first jejunal vein-oriented SMA-first approach and conventional portal vein-first approach. See this data, the blood loss is obvious in first jejunal vein-oriented method. One of the important points is in almost all the cases, we can find the drainage vein from pancreatic parenchyma to first jejunal vein. Here you can see the small drainage vein. In the normal anatomy, this drainage vein is around here, so we usually take care of the injury, not to injure this drainage vein. So the next we show the video of the first jejunal vein oriented artery first approach. The pancreas is already cutted, and now we can see the superior mesenteric artery, and now we divided the neural plexus of the right side of the neural plexus of the superior mesenteric artery. And now the assistant ligates the distal part, distal margin of the neural plexus. Here is the first jejunal vein. This is the first jejunal vein, and this is superior mesenteric vein. Now ligate the posterior margin of the neural plexus of the SMA. And here is a splenic vein, so we can usually find the inferior pancreas duodenal artery between the splenic vein and first jejunal vein. And now here is the IPDA, inferior pancreas duodenal artery from the SMA. And now you can see the operator's finger. So usually that IPDA is we can find one or two IPDA, and another tissue is not include the artery, so we can cut it. And then the drainage vein from the pancreatic parenchyma to the portal vein is divided. So there is a few bleeding from the pancreatic parenchyma because that the blood supply from the artery is stopped, and there is no congestion in the pancreatic parenchyma. Then almost detached from the portal vein. And the final step is to detach from the first jejunal vein. And this is the conference of the first jejunal vein to the superior mesenteric vein, and this is the small drainage vein from the pancreatic parenchyma from to the first jejunal vein, and ligate and divided. And then complete the pancreas duodenal artery. And total blood loss is 400 milligram, and operation time is 4 hours and 30 minutes. And the next case is also the anterior approach. ビデオ2を出してください。Now that the splenic vein is taped, and this patient is very thin, and the connective tissue between the superior mesenteric artery and the portal vein is very thin. So this procedure is very easy. You can see already my finger from the posterior side of the superior mesenteric vein. And now we ligated the inferior pancreatic artery. And another place that you can use the ligature, because there is no artery in this side. Now cut the celiac plexus, and then the pancreatic parenchyma is detached from the artery. 止まった。止まった。あ、もう一旦か。失礼しました。So another approach is the mesenteric artery. This is a good procedure for the advanced pancreatic cancer located in the pancreatic uncinate processes. And this is the first step of the pancreatic artery. And we can assess the resectability of the pancreatic cancer in this step. So the most Japanese surgeons use this method for the advanced pancreatic cancer. Another approach is the posterior approach. This is a good procedure for the very obese patient or the patient who had the anomaly of the hepatic artery. これは、もうビデオ出さなくていいです。ビデオ、3番目のもうビデオは出しません。いいです。So, the posterior approach is very useful to the patient who have the replaced right hepatic artery from the originated from the superior mesenteric artery. And this method prevents the injury of the replaced right hepatic artery. This slide showed our recent experience of the pancreatic duodenectomy. We have usually the 50 to 60 cases of pancreatic duodenectomy for a year, and as you can see that we introduced the artery-first approach from 2008, and bleeding, intraoperative bleeding decreased to about 900 milligram, and the operation time also decreased to around 6 hours 30 minutes. So this is the last slide and the conclusion. There is several types of the artery-first approach, and the range of the number 14 lymph node along the superior mesenteric arteries, the origin of the SMA and the middle choric artery, and the origin of the SMA is usually located just behind the splenic vein, and origin of the middle choric artery is located at the level of the confluence of superior mesenteric artery and first jejunal vein. And this is the most important thing, is that inferior pancreas duodenal artery from the superior mesenteric artery is usually located between origin of the SMA and first jejunal vein. And the first jejunal vein is 20% of the first jejunal vein run cross over the superior mesenteric vein, and drainage vein from the pancreatic parenchyma is flow into the first jejunal vein. And this is important not to injure the small drainage vein. And the cranial side of superior mesenteric vein is there is no IPDA, and just you can find the celiac plexus. So in this area, you can use the energy device. You don't have to ligate the connective tissue. That's all. Thank you very much.
Thank you. Thank you, Dr. Wotska. Your presentation was, with excitation, followed by my two colleagues on my side. There were two surgeons who were really excited to see your beautiful techniques, and there are a few more surgeons in the audience. I hope they understood much better. But what the general people here, or general audience, could understand, that by this telemedicine technique we can learn very minute details. We can really follow very minute details of the operation. So educationally, this is very exciting that people can learn from a distance all the details of such kind of operation. So that is from the, I think, the exciting part of this from the general audience. Probably Sarder Nayeem will ask you something, but we would request that, keeping view of the general nature of the audience, we should not go into many technical details of the operation, but the main point would be to really for the general audience. Thank you.
Yeah, thank you very much, Dr. Wotska. It was a great lecture, especially for the surgeons, hepatobiliary and pancreatic surgeons, definitely. But luckily, we have some surgeons here. But I was really excited because the streaming and the lecture and your video from Kyushu was fantastic, and we could understand everything. So it is a great way of learning, and that's I know today probably in this audience not many persons will understand this surgery, but they're understanding that it is very possible to do a live streaming like this, and taking a class or doing training purpose, research, everything is possible by this high-speed network. And thank you, Dr. Shimizu Sensei and Wotska Sensei. Thank you very much. And I will have some comments from a surgeon here. He's a professor of surgery from Bangabandhu Medical College, and he is also doing hepatobiliary and pancreatic surgery. Yeah, Dr. Sofu.
Thank you very much. Mr. Sukar, I am Professor Saifuddin Ahmed, Bangabandhu Sheikh Mujib Medical University, working as surgical oncologist. Thank you very much for your presentation, and we already seen one thing. It's a sophisticated operation called Whipple's operation, pancreatic or duodenectomy. But in our country, we have been doing this thing. And we just, in our country, in pancreatic patient came to us, and lately, for this reason, we just do triple bypass operation commonly. But Whipple's operation is a highly technological aspect, should be considered. one thing is very, very important to us, that to select some tributaries and also the branches of superior mesenteric arteries. And for this reason, we just could not maintain the postoperative stage of this operation. And for this reason, the technical aspect is very, very important in our country and as well as the global area. So thank you very much for your presentation. We hope to proceed, and we want to proceed ourselves in our technique. Thank you very much.
Thank you very much.
About our Nepalese friend, Dr. Saros, are you here? Hello? Hello?
Yes, yeah. We are here. We are mesmerized. We are really mesmerized. And I don't know if we should be talking about the technical, the IT technology or the surgical technology. Definitely, we will be learning more about the surgical technology, and we understand that the artery first method is definitely going to be very rewarding, and we have already started talking about that. Shall we? Do you have enough time to play with this, storm footage now, or we don't have any time?
Saroj, could you please demonstrate it for us so we can go back to the movies so that you can add some, illustration on it?
So at the meantime, I have one question. What is your experience with this anterior approach in obese patients?
Yeah, I think, could you get the question? What is your experience with obese patients?
In the obese patient, if you'd like to do the anterior approach, the reverse T incision might be better, because that you can see my left hand is in obese patient very difficult to hug the pancreatic lesion. So you can use the reverse T ski incision to get a wide surgical field, or you can choose the posterior approach.
Okay, thank you. Now we want to demonstrate the.
We don't want to demonstrate, we want to learn, just for a few minutes. We are red, right? So now if I start playing it, and
Please enter. Please enter.
Sorry. Annonation.
Oh, Bangladesh is much smarter than me.
So red arrow is now being controlled by Nepal. So please, point somewhere, or please draw the line, or whatever you can do. Please, demonstrate something, asking questions.
Oh,なるほどね。
यो ऊ होइन पज गर्नुपर्छ
पज गर्न सोध्दा हुन्छ होला नि पज गर्दा नि हुन्छ
So tell us about this vessel.
この結果なんか。
That's a good question.
で、
के हो?
あのテンションだよね。
के भयो?
This is a superior mesenteric vein.
Okay.
Here is a. This is the splenic vein. Splenic vein. これだね。
Okay, can you show us this celiac plexus?
No. Here is a celiac plexus. We already divided.
Okay.
And now see the small drainage vein from the pancreatic uncinate. Oh.
Are these male fingers or female fingers?
Oh, yeah. So, yeah. Really
Very
nice.
nice.
I'm sorry.
Adding color to the questions, right?
Okay.
I think.
Hello.
Oh, yeah.
Okay, I think that was a very good demonstration, and Dr. Sharoz, we have to move because there are other sessions going on and people have to join. So thank you very much. Very nice, and actually the most interesting part is the technology, and it is working. We can see how nicely it is working. We will move forward, and I hope in future we can have so many interactions in this way. So we would like to thank Dr. Otsuka and of course Dr. Shimizu and the colleagues in Japan for this excellent demonstration and presentation. Thank you very much.
Thank you very
I
much.
would like to now move towards another Japanese-trained surgeon, Professor Dr. Sarder Abdul Nayeem. He is presently the Chief Laparoscopic Surgeon and Chairman of Japan Bangladesh Friendship Hospital. And he is also a medical graduate from Dhaka Medical College, and he was trained in the faculty of medicine as well as in the Department of Surgery, and got his PhD from University of Tokyo in 1993. After that, he came back to Bangladesh, joined BUHS, and he is the person who first introduced laparoscopic surgery in Bangladesh. So we all owe a great deal to him. And then, of course, he stayed in BUHS for a long time, and presently he is a professor in the Department of Surgery in Uttar Adhunik Medical College, and also chairman, as I said, of the Japan Bangladesh Friendship Hospital, and also Association of Medical Doctors of Asia. He is the president of the Bangladesh chapter. He got many awards from his students' life, and then also in his working life. And he served in the editorial board of few journals, and he is co-author of the two books and published 34 scientific publications. So with this brief introduction, I would like to invite Dr. Nayeem to kindly present his topic, and he will speak on exploring the possibilities of using high-speed internet in endo-laparoscopic surgery training. I'd just like to remind that we have 15 minutes in total.
Yeah, thank you.
Because we have other programs. Thank you very much.
Thank you, Professor Liaquat, for your nice introduction. And Dr. Shimizu, are you hearing us? Hello?
Hello, Dr. Shimizu, a little bit leaving. Okay. So the
Otsuka-sensei is there? Okay.
Yeah, Otsuka-sensei also.
Yeah.
Sorry.
Yeah, no problem. They call me Japanese Nayeem here, so Dr. Liaquat introduced me as from Japan. Anyway, this is a very assorted audience because there are very few number of doctors and mostly engineers and educationists, and I will try to make my presentation as general as possible and not very specific. We know the introduction of telemedicine, the practice of medicine by teaching the medical art without direct physical physician-patient or patient-student interaction is called telemedicine. We all know it. At the same time, why I'm going to speak today on endo-laparoscopic surgery and telemedicine, because I was trying to find out the relationship and how we can develop our education and training system by telemedicine. And surgery has experienced a huge deal. It is more than 2 decades we have introduced laparoscopic surgery, and it was a real revolution in the field of surgery. And laparoscopy was possible. This is the same surgery. Actually, laparoscopic surgery is not a different surgery from open surgery. You have seen this surgery just few minutes ago. This is also can be done by laparoscopy. And many people are doing pancreatic duodenectomy also by laparoscope. So, and it is only possible because the camera video system and surgical instruments, some special surgical instruments, and surgeons had to develop some special surgical skill. In front of me, Dr. Saifuddin and Dr. Kalam Chowdhury, they're also laparoscopic surgeon as well as open surgeon. So there is no difference between open and laparoscope. Only the portal of entry is different. We enter in the abdomen by opening the abdomen in case of open, and we enter in the abdomen by the help of a camera in case of laparoscope. Laparo means abdomen, scope means to see something with, so that is laparoscope. And in Bangladesh, we have studied in 1991. It's quite early. And incidentally, Dr. Liaquat told you that I was the facilitating factor. I came back from Japan. I was a student there. And with Dr. Hashimoto, I have performed the first laparoscopic surgery in Bangladesh. These are the 2 cases we have performed in Bangladesh. And you understand the benefit. This is for the general people here. The benefit of laparoscopic surgery is huge. And that's why this laparoscopic surgery is gaining popularity very quickly. When back in 91, I thought the term laparoscope is quite a difficult term for general people. It was a very difficult term, laparoscope, even for the doctors. But nowadays, even a rickshaw puller comes to me and tell me, sir, we computer the amar operation kore den, or sir, we leprosy kore amar operation kore den. So everybody at least know the term, but this way of doing surgery just because of the benefits. The benefits are very obvious. You know, you open an abdomen and you don't open an abdomen, the same surgery you offer, you understand the benefit. I don't need to go into details. So telemedicine was also started quite early, and it is not a new thinking. But now with the tools of high-speed internet and all this development, we are really going into this telemedicine. And information technology and healthcare, all the presenters before me, they mentioned about it, so I'm not going into details. And you know, the teleconsultation, telemedicine, or this telephonic conversation, or this internet, or high-speed network, whatever it is, or e-health, whatever we call, we talk about teleconsultation, then we talk about telementoring. Because Professor Shimizu at the beginning, he told the things, the doctor-patient, doctor-student, and for teaching purpose. This is telementoring when the surgeons is doing a surgery and mentoring it, and or a young surgeon is doing a surgery and it is mentored by a senior surgeon. This is telementoring, and telementoring in endoscopic surgery is the most suitable and most possible way of doing using this network, high-speed network. And you know, the robotic surgery is another surgery. Now I have some things to tell you. We call telesurgery. Telesurgery is also a misnomer. Telesurgery means I'm here, I'm doing a surgery on a patient who is lying on an operation table in Chittagong. That is telesurgery. So when I'm doing a surgery on a patient and viewing in a monitor, and that view can be showed in Chittagong, there is telementoring, or there is some kind of, you know, there's a training purpose we can do that, but not doing the surgery on a patient in Chittagong. So see, the telesurgery terms is very confusing to me also. What is telesurgery? Like robots. This is robotic surgery. It's a master robot and slave robot. You keep the master robot in Dhaka and you take the slave robot in Chittagong. A nurse can set the slave robot on a patient in Chittagong, and a master robot can be controlled by me from Dhaka. That's a robotic surgery. it has already been performed, and master robots also can get assistance for that. So in robotic arms, there are multiple arms of robot. The robotic arms on a patient in Chittagong could be controlled by a group of surgeons from Dhaka. And it is already a reality now. Already a surgery, the first remote procedure on a patient occurred in September 2001. It's all 15 years ago. They have done a surgery from France on a patient by an operating surgeon from New York. So it is a reality. But we'll have to wait for that in a country like Bangladesh or developing countries. But dream is dream. We can dream of it. So at the beginning, at this moment, telemedicine in endoscopic surgery should be used in remote teaching, skill development, knowledge sharing, and professional improvement by teleconferencing, like what we did with Kyushu University. There is a fantastic teleconferencing and interaction session, and real-time mentoring and assistance in surgery. That is important. Somebody was telling that why don't you just take a class in real time? Why not just put a video? And I liked Professor Misbahuddin's answer very much, because real time is really different thing. Because I have got more than 700 videos on YouTube. Just put my name and see Dr. Naeem's lab videos. But still, I find whenever a student is watching my surgery in a real time, is much, much better orientation and learning. It's no match. Otherwise, everybody could learn from videos. So live surgery, watching live surgery and watching videos. I put all the videos on YouTube unedited. Not a single minute edition I do, just for learning purposes. But still, I believe watching live surgery is more important than watching videos. But of course, videos also helps, no doubt about it. So telesurgery or remote surgery, we already know it. And we know the demonstration and teaching purposes, it could be used properly. And now, we should really put some guidelines. Before jumping into anything, we need to have some guidelines. Guidelines is important because telerobotics should undergo telerobotics and telesurgery is not that easy. Suppose I'm doing a surgery from Dhaka, and the patient is lying in Chittagong, and if you have any problem, a life is concerned there. So you will have to have a experienced surgeon there also to take care of it. Maybe a technical fault, a technical failure, you cannot just play with a life. So time will come when we can overcome all these things, but at the moment we will have to have a proper guideline before doing all these things. And you know, the all involved participant facilities, telecommunication equipment, vendors, they should make a team of, otherwise, and everybody will have to be involved in that team. And well, laparoendoscopic surgery, why I'm talking about this? Because I believe the laparoendoscopic surgery has a huge range of surgery in every field, and endoscopic surgery is being performed in every specialty now, you know, in urology, in orthopedics, in ENT, general surgery, gynecology, of course, the basis, and even in neurosurgery, cardiac surgery. So this, and the most important thing is whenever the video doesn't work here, isn't it? These are videos. See, you are seeing a operation field here, and this field is seen by me. I was doing this surgery just watching this field. So at the same time, I can teach my students showing this who are sitting throughout the whole country in different places. Live surgery and live demonstration. We are now doing it. Suppose in Bardem Hospital, operation theater, the operation we are doing, we are transmitting it to Bangabandhu Medical University. So when we do the workshops of laparoscopic surgery. So this is something like the same. Now we do it by cable. Time will come. Or now BDREN can help us in doing these things by high-speed network. It is possible. And you know, I just wanted to show you some now you will have to also think about the legal aspects of this telesurgery or telemedicine, whatever, because you know the life surgery by its very nature is number of people are involved. Here the privacy of patients are also involved. Whether the patient is interested to show her or his problem through the whole country by high-speed network. So you'll have to take permission from the patient. You'll have to take permission from the related personnels. So this is also important. And also another problem is when you are showing it nationwide or in different places, and you know the legal aspects also come. Complication is a part of any surgery. There is no surgery, no surgeon can tell that I never had any complication in my life. Human errors are there. Whenever a surgeons are doing, suppose let me tell you an anecdote. Professor Motir Rahman, you know, he's a very witty person. He's a witty person. He's our teacher, all of our teachers. He's the teacher of the teachers. ওনাকে যখন কোন রোগীর লোক রিকোয়েস্ট করতে স্যার আমি কি অপারেশন রুমে থাকবো, উনি অনেকে থাকতে চায় না অপারেশন রুমে, যেমন ডাক্তার, রোগীর লোক মানে ডাক্তার, আমি বাংলায় বলি এটা। Well, I think I should speak in English because our Nepalese friends are there. If some relatives of a patient, you usually ask him, sir, I want to be in the operation theater because I'm a doctor. My patient is my relation. Sir, very witty. He was a witty person, and he used to tell that if you are in the operation theater, my hand will shake. Do you want me to do a surgery on your relatives when my hand will be shaking just because of your presence? So, whenever a surgeon will know, the whole countrywide, all the students, thousands of students are watching that. That is also an important factor. So there are many factors. We'll have to think and overcome all these things. So there are some suggestions. These are the suggestions not to be taken in a minute or in a day. So we'll have to make a group of people, including everybody, and then sit together and take the suggestions. And brainstorming, with brainstorming, we can go for it. So if I conclude, the endo-laparoscopic surgery, the primary surgeons automatically share the same operation field with everybody. So the role of telemedicine or telesurgery is considered to be the most in the field of endo-laparoscopic surgery for teaching, training, performing, and so on. Proper setup and teamwork must be obtained. Proper training and orientation is of highest priority. Patients' privacy and legal aspects must be in consideration. Thank you very much.
Thank you. Thank you, Dr. Nayeem, for your excellent,
thank you.
Excellent time management, and I think excellent overview of the telesurgery. Since we are running behind time, we will allow one or maximum two questions. Be brief, please, for commenting or any question to Dr. Nayeem.
Thank you. I'm not asking anything from the medicine. This is my part. We are discussing about the tele thing. Tele. Tele just comes as our mind as a telephone.
Right.
But we are progressing towards high-speed internet. Can I suggest the authors and the presenters to think this to be the e-thing? It may be e-medicine, it may be e-health, it may be e-surgery. Thank you very much.
It is already raised. Professor Misbahuddin told because e-health and nomenclature is a problem. You know, the telesurgery itself is a confusing nomenclature. Telesurgery means you are sitting here doing a surgery on a patient there, or telesurgery means you are doing a patient on a patient here and distributing it through the country. Distance. Tele means distance. So telesurgery, telemedicine, telesurgery, these are the things we'll have to rethink about it, about nomenclatures.
I think we can go on with this
Thank you very much.
perfection, but sometimes it becomes a brand, the name.
Right. Sometimes
anyway, anybody else want more question?
Like any motorbikes in the Bangladesh is Honda. You cannot help it.
Otherwise, we have to move to the.
You cannot help it. So you'll have to accept sometime. If you understand, then go on with that.
The connotation
actually,
is more important.
This laparoscopic surgery is also the nomenclature was difficult. So initially, we started minimal invasive surgery. minimally invasive surgery. Later on, we thought, oh no, it is not minimal invasive. We do maximum invasion, but with minimal access. Then we changed the name to minimal access surgery. So things are developing so quickly. We are also out of time because we cannot take a proper decision of making a name properly. Thank you very much. I think.
Okay, thank you very much. We will move to the last speaker of this.
Last but the most important.
Yeah, most important.
Most important.
Yeah, we have Professor Abul Kalam, Dr. Abul Kalam Azad with us. He is also a medical graduate with his post-graduation in medical biochemistry, and he served in Dhaka Medical College, Mymensingh, Rangpur in various capacities. Lastly, as professor from Rangpur, and then also in IDCR and NICVD. While in Ipsum, he also served as the editor of the Journal of Preventive and Social Medicine. And since 2008, he is serving as the director of MIS at the Director General of Health Services. And from 2011, he has the additional responsibility of ADG, Planning and Development. And also from 2016, he has additional responsibility. So he is burdened with additional responsibility with admin, and he has several publications in national and international journals. But the most important is that he is an enthusiast and pioneer in, I should say, dragging the government into, e-health aspects and in the healthcare. With this introduction, I would like to invite Professor Azad to speak on telemedicine service under the Ministry of Health and Family Welfare in Bangladesh.
Thank you, Liaquat bhai. You are my guru for kindly introducing me. I think in a brighter way. Perhaps actually I am not of that type. Okay. And also to BDREN for kindly inviting me to this program, and dear audience. And virtually we have gone through the academic lectures, and I think the true actually definition of telemedicine is use of this telehealth for clinical service, for maybe teaching the medicine. But telehealth is a wider thing, and e-health is further wild. When any use of ICT in health is e-health. And my purpose is to describe the preparations of the Ministry of Health and Family Welfare of the Government of Bangladesh about the infrastructure of the telemedicine. But before coming here, actually, I have narrowed down my topic. I understood that this is truly about the discussions of medical education and research in health. But after the presentation of Dr. Liaquat Ali and maybe the presentations of other colleagues, maybe I shall contribute some more to give you an understanding that what is the real preparations of Bangladesh in terms of infrastructure. It is not about the medicine, telemedicine, it is about the maybe health information system and e-health. And this will help you if you are really interested to take the advantage of the preparations of the government. Actually, you will have ample opportunities to do this. Okay. So I like to actually share this slide to you. On the right side, there is a book. This book was published in 2014 by the German government, and it was officially launched in Berlin. The title of the book is A Quiet Revolution, Extending the Routine Health Information System in Bangladesh. And now this is a popular reading among the people actually who wants to use health information system or technology for improving the health information system and understanding the country's situation in terms of the health and I think the other service delivery. On the left side, at top, you see that our Prime Minister is receiving an award, and this person who is giving the award in the United Nations to our Honorable Prime Minister, he was the earlier Secretary General of International Telecommunication Union, and he personally visited Bangladesh, and he has witnessed actually all those infrastructures in Bangladesh and the delivery of services in health through use of ICT. And then he recommended to United Nations to give an award to Bangladesh. So this is the scenario of 2011, and we started building this kind of infrastructure from 2009. So only after 2-3 years of work, Bangladesh has got this recognition. The bottom picture, the middle picture on the left, Actually, it is taken from the website of Health Data Collaborative, which has been launched on 9th March of 2016. You know, we are now in the SDGs, Sustainable Development Goal. And SDGs call for individual tracking for every citizen, for health and for other purposes. And for health, this Health Data Collaborative has been officially launched in 9th March 2016 to help countries to build the capacity so that the country can individually record or register every citizen and can track the citizen for their health. There are 20 members in this group, and Bangladesh is the only country as a national member. And you see the logo of Bangladesh, it is shown very prominently. On the same day, on the occasion of the launch of this organization, Health Data Collaborative, virtually the major sponsors of this collaborative is World Health Organization, World Bank, and United States Aid. And 20 other development partners, including Bangladesh, are the members of this. So on this particular day, 9th March, WHO in its website made a top story, and it featured Bangladesh as the most successful country in the world to measure the progress of SDGs in health. So this is the recognition of Bangladesh from global perspective. Health Data Collaborative has decided to organize regional conferences in different regions of the world, and the first regional conference will be held in Bangladesh in 26, 27, and 28th of April this month, the last week. So this is the recognitions of the preparations of Bangladesh. Lastly, most of the resources we invested or we bought from the money actually given by the World Bank as a soft loan. And World Bank has a perception that whether this investment is giving some return of money. So they actually performed an international study, and they visited 800 places. They directly interviewed over 1,500 persons, and they have circulated their email questionnaire to about 13 or 15,000 people. So from this study, they have understood that the investment in Bangladesh is working, and Bangladesh's e-health environment returned good value for money. So this is the observation of this international study done by World Bank. So this is the progress of the Ministry of Health in terms of investing in e-health. So I like to say about something about the telemedicine, particularly the telemedicine we are providing in Bangladesh. This is for healthcare. It is not for medical education. But somehow, I think indirectly, these are also helping in education. But if our colleagues, particularly the teachers in medicine in Bangladesh, medicine means it is not medicine, it is surgery or all the different branches of medicine. If they are enthusiastic like Professor Misbah, I think then we can use our resources for broader perspectives in delivering medical education, teaching, and the research in health services. And when Professor Misbah was actually speaking here, at the end I had a question. I did not get the chance. My question was that, Professor Misbah, you are working for actually several years actually in this, and your presentation shows that you are a dedicated person, but only one Misbah will not be enough for Bangladesh. So how many Misbahs you have created, or what are the reactions of the different Misbah we are looking for? So that question we need to ask ourselves. So we have actually, we tell about telemedicine that this is different kinds of telemedicine. It is not only for advanced equipment and other things. As Professor Liaquat, he has mentioned that simple SMS can be a tool for telehealth or telemedicine. So this is one of the tools we have created. This service is available 24 hours, 7 days, and we call it Shastho Batayon. Why we call it Shastho Batayon? Because the government of Bangladesh has a Jela Batayon, district window. It means we have the website for every district. So in the same name, we have given it the window for health, Shastho Batayon. So this is a number. This number is 16263. In Bangla, we call Ek Bashotti Teshotti, so that the people of Bangladesh can easily understand. Last 6 months, we are providing this service. But we did not formally inaugurate this because our Honorable Prime Minister was willing to inaugurate it formally. So we waited for last 6 months. But now the Prime Minister is so busy, and she told that, you do by your Honorable Health Minister. So next 24th of April, our Honorable Health Minister will formally inaugurate this. But this service we are providing for the last 6 months. You can call this number from here and you listen what kind of service this system is providing to you. So what we provide? We have got doctors there, and they provide live consultations, and there are MBBS doctors as well as FCPS and other postgraduate doctors are there also. We can book an ambulance. We can call an ambulance from anywhere in the country. So you simply call 16263 and you ask them to book an ambulance for you.
Then we have content management. So there are many contents and people ask for health informations. If this information is not readily available there, these people will take your contact number, and when they will collect this information and will get back this information to you when this will be ready. Then we have got complaint management. We have got healthcare providers, both in the public sector as well as in the private sector. We have individual provider, we have got organization providers. So any clients of Bangladesh, any citizens of Bangladesh, if they have got any complaints, or if they have got any suggestions to improve the services of those different kinds of providers, they can lodge a complaint or suggestions to the system. And some of those complaints are available on the website directly. And we are thinking that many people, they go to the outpatient departments of the public hospital. They also go to the private practitioners. Can we manage the appointment of these people? Because they come in the evening or maybe in the morning in the outpatient department of a government service. They wait there for 4 to 5 years to get a doctor. So we can easily manage this kind of appointment system. So we are actually trying to build system so that by SMS, by simple SMS, or by calling to this number, we can actually get an appointment in the outpatient departments of the government and the private institution, as well as with the private practitioner. Earlier, actually, we established a system in 582 hospitals. Actually, it is not 582, it is 482 hospitals. All the Upazila hospitals and all the district hospitals. There is a dedicated mobile phone in the particular hospital, and the citizens living across this organization, they can call this number. And a doctor always carries this telephone, and he receives this call, and he advises the people as they're asking. Now we have expanded these services with Skype to the community clinics. So in the community clinic, there are no doctors. As of now, we have got 13,300 community clinics, but there are no doctors in the community clinic. There are healthcare providers, the paramedic, they provide the service in the community clinics. But for some patients, they require consultation from an MBBS doctors. And we have video conferencing system, not advanced, maybe with Skype and the web camera. So they have a link with the doctors working in the Upazila, and the patient then can directly talk to the patient, a doctor. I wanted to show a video to you. Time constraints, I like to save the time, and I shall skip this. This is the first telemedicine service we provided with Skype, and Shuji was a joy, inaugurated this formally, and Shuji was a joy in our Dhaka office, and the patient was in Kumilla. So this is the scene. On 16 April 2009, we have actually formally inaugurated with an ordinary computer. But advanced telemedicine we introduced in 2010, and Honorable Prime Minister is seen to actually formally cut the ribbon to inaugurate this. So this is the actually current numbers of the telemedicine centers in Bangladesh. So this year we are going to add 35 different centers, and if these 35 are added, we'll have 94 centers virtually. And the Ministry of ICT divisions of the government, they have helped us to contribute 25 centers, and their plan is to expand it to 100. But for the Ministry of Health and Family Welfare, personally for myself, actually I am not interested to expand the services. The reason is that in all those centers, we have got dedicated bandwidth. We have got costly equipment, but the use of these are not actually that much. Actually, I think it's not satisfactory. And if our colleagues are not interested to use this system, this will be merely only investment, not cost effective. So, you know, before investing, before expanding the services, we need to actually think twice that whether we'll invest that much of money if we cannot use this efficiently. For political reasons, we need to sometimes scale this, right? So for the actually standards, Professor Nayeem has mentioned that we need standards. Virtually in Bangladesh, we have a telemedicine guideline for using in the mobile phone as well as for using with this advanced technology. So we propose people that the equipment should be of American telemedicine standards. So what are the equipments we have? These actually follow the standards of American telemedicine associations. So in the central level, the sophisticated hospitals, the tertiary hospitals, we have got multi-point cameras. The cameras can move. But in the remote centers, we have got single-point camera, and we need to actually manually manipulate this camera. But we have these gadgets, the gadgets listed in the lower portion of the slide. We have gadgets in all the telemedicine centers, so that without actually bringing the patients for non-surgical cases, they can actually refer the patients to the specialist in the higher centers. But the problem is that the specialists in the higher centers, they are also not that much willing to provide the services to the remote people. But we make a difference between the ordinary referral we make. When we refer a patient to maybe Dhaka Medical College Hospital or to Bangabandhu Sheikh Mujib Medical Hospital, Bangabandhu Sheikh Mujib Medical University Hospital, so we simply write on a paper. And the patient is helpless. They do not know where to go, to whom they need to go. There is actually no one to greet them in the hospital. But here, on the other side, in the remote places, there are doctors present with the patient. And actually, they manage all those things. They organize the specialist. They help the patient to actually describe their health condition, etc. So the people, they feel very satisfied. They feel very confident, right? And maybe they have got people to support them. So these are the difference between the telemedicine as well as the normal, ordinary referral we make in Bangladesh. So if the doctors working in the remote centers who actually very frequently refer patient by simply writing on a piece of paper, if they take advantage of this for non-surgical patients, I think many of the patients can be dealt remotely without advising to travel long distances to get the specialist help. So this is, I don't know how I cannot play. Anyway, the video is not playing. So we can demonstrate that how this medicine session takes place. On the upper left corner, this is our monitoring cell, a coordination cell located in my office. On the upper right corner, the remote center. On the lower left corner, on the upper right corner, the specialist. And the lower left corner is the remote center from where the patient is being referred. So I like to give one example from North Korea. I visited North Korea in 2013, and you will be surprised to know, in North Korea there is no public internet. The ordinary citizens in North Korea, they are not permitted to use internet, and virtually there is no internet, that much bandwidth available in North Korea. Only they get the internet from China, but they have got fiber optic network up to the rural area, and they use intranet. They use their own local national content to use through this. And they are using marvelous use of telemedicine and telementoring using this network. So this telemedicine network has been supported by WHO. And during our visit, 213 hospitals were covered by this system. All the provincial, city, and country hospitals are covered. And these are actually the picture of the telementoring. They have studied that average 3.1 days per patient, shortened the lead time of the treatment. They have reduced this time. And they have reduced the referral by 25%. Since the introduction, actually for the tele-education for the medical students, since February 2010 to June 2013, they organized 144,506 sessions for the audiences. It is not the number of audiences. Oh no, this is the audiences, right? And there are 1,432 sessions, and they held during that period of time. So these are very much cost effective, because the investment they made, actually they are making good use of this. And we have also seen that maybe in the remote centers there are accidents, and there are no good surgeons available. Junior doctors are working there. They do not know actually how to conduct the surgery of these emergency patients. But it is actually not safe for the patient if they actually take the risk of actually transferring the patient to a distant hospital, as a better hospital. So what they do, the good surgeon, they work in the main center, in the headquarters, and they use this technique. The surgery is taken place on the remote places, and they guide from here what to do, where to cut, and how to stop bleeding, how to sew, like that. So, they are really using the system. And virtually, we have seen that I have visited several countries to see the telemedicine. And I have really, amazed to see the use of the telemedicine and the cost-effective and efficient use of telemedicine in the North Korea. They have got actually resource constraint. But and they don't have enough international cooperation to build the system. But still, they're making mass use of the system for which they have invested. For Bangladesh, I have got some recommendation. So one is virtually in Bangladesh, we see this is a small country with a huge population and the plain land. So anywhere if we place one health worker or a small community clinic, immediately creates a huge access to the people. So actually getting a healthcare provider or health facility is not a problem in Bangladesh. Rather, getting the diagnostic services in the remote places, in the periphery is a problem. So through the telemedicine or telehealth, whatever we call, we should expand the diagnostic services to the periphery so that without having a specialist, pathologist, or maybe or whatever, or radiologist, we can expand the diagnostic services to the remote. And this information on the diagnosis can be transmitted to the doctor or maybe to the specialist at the remote places. This is one. The second, virtually, most of the successes I have seen in the first slide, this has come from the work of the community health workers, the doctors working in the remote places, but not from the medical college hospitals, the tertiary hospitals, and the professors working in the medical colleges or the postgraduate institutions. But if you actually see the whole paradigm of the medical systems in Bangladesh, you will see the most educated person, the most sophisticated person, the most knowledgeable person, they are working in these places. So if these people do not take the leadership, the success of the investment will not be returned. So that is a message. So we have got sufficient resources already available in the country. But if we cannot use these resources, if we do not use the resources, we should not further scale the investment. That is actually, I think we should keep in mind these messages. Otherwise, for this kind of session here, this should be almost frequently in all the medical colleges. Why not? Actually, these are happening there. Why we are doing here and inviting people, and this house is not full, right? So we will have to actually keep in mind the reality, and we should encourage our colleagues so that they come forward. Unless they take the leadership, this will not be successful. Thank you very much.
Thank you, Professor Azad, for the exciting and very stimulating lecture. Ladies and gentlemen, as you have learned that a lot of infrastructure has been developed in the country, but unfortunately we are not using it. And the most, if I call, the responsible people is the group of elites, medical elites. The medical elites, we are not really using it properly. And I think the message is very clear. Bangladesh has made a lot of advancement, and although he was modest, I can repeat that yes, he has played a very, I should say, driving role in the government to make the government interested in this field. Ladies and gentlemen, and another take-home message is that if North Korea can do it, why not we? I didn't know about this honestly before this lecture. So with this, I think we can go forward with some questions. There must be bubbling. You must be bubbling with some questions. Please, Dr.
Amin. My name is Aminul Islam, Assistant Professor, Department of Health Informatics, Bangladesh University of Health Sciences. I really appreciate your initiatives in health sector in Bangladesh. So it's really amazing to hear the story, the improvement and the implication of telemedicine in Bangladesh. So my question is actually, so you mentioned that you have 43 telemedicine center, but do you have any assessment of patient outcomes? So I was just wondering to hear from you.
We didn't have actually formal patient assessment, but two kinds of things. One is number of the patients we are encountering, I think maybe every month or on yearly basis. And second, we have some patient satisfaction survey. It's a random kind of survey. Patients are very satisfied. The reason is that patients do not feel themselves helpless. and they feel the doctors working in the remote hospitals, actually they are taking care of their diseases. And the second, virtually if the patient know that there is presence of telemedicine in the center, they ask the doctors to help them to get the advices from the specialists. So if the doctors, they take the role to make the system popularized, right, I think patients will be highly satisfied. At the same time, they will be immensely benefited. But you will be surprised to know that the number of daily patients from 43 centers on average between 20 to 30. So, you know, on an average it is less than one patient per center. But of course we'll have to think that these are referral cases. These are not all the cases. So the number will be much less compared to the number of patients in the outpatient. But still, the number of papers we are using for referring patients directly, these number are far more compared to the number we are using actually taking benefit of this system.
It is, I have a single question. You are working in the policy level, and the surgeon is using telesurgery, medicine people telemedicine, dermatologist teledermatology. Do you think that there should be tele-regulation like in North Korea?
Regulation. There is no tele-regulation.
No, tele-regulation because we are using internet internally or externally, and we are misusing, just like in Korea, there is some regulation, and they are using it properly. That is why I would like to say the tele-regulation. That is
no, virtually we have already regulations in Bangladesh about the use of actual safety of internet and use of this mobile network. We have already done. We need to actually have some maturity in terms of having an act. We are actually thinking that we will require act for using the e-health in Bangladesh, and virtually you will be amazed to see that we are introducing electronic health record for the citizens, and this is already introduced in Kaliganj Upazila of Gazipur district, and we are expanding to Gazipur Medical College hospitals. But the software is one of the most sophisticated software in the world. We have especially made for this. And perhaps Bangladesh will be the only country in the world which will be able to measure first measure actually the progress of AIDS disease through tracking individual citizens. In last February, I visited New York. It was about the monitoring of nutrition data for producing the UNICEF World Health Organization report. I was surprised to see in the beginning of the meeting I told that for years we'll have to depend on the surveys because the routine data probably will not be able to give us reliable data. But at the end I told them I am withdrawing my comment. I have seen that even no data is available for the developed country. There is no data for the prevalence of exclusive breastfeeding for the United States. And their statistics department, they do not care the WHO and UNICEF. They say we understand better, but they don't have the data. This is one. The second, they have, in many countries, there is no data. So they conduct a survey of 400 people, right, for a population survey. And this report is published in the World Health Report and UNICEF report. In Thailand, they have given an example. In 1 month's interval, they have conducted the same research with the same methodology. Still, the data are too much different. So that is the case of the World Health Report and UNICEF. And compared to that, Bangladesh data are much more reliable. So probably Bangladesh is going to be the first country in the world to have the measurement of the AIDS disease. Thank you very much for this call.
How can we get the list which are provide this telemedicine service?
Okay. Virtually in my computer I have one, and you can take a copy of that, and probably we have a list in our website, right? But you can take a copy from me now. Okay.
Well, I think we had a very, stimulating. You have a question.
Okay, thank you very much. I am Professor Mir Misbahuddin from Khulna University. Basically, I am working on signal processing or data processing for medical diagnostic purposes. আমি আসলে যে জিনিসটা বলতে চাচ্ছি বাংলায় বলি যে আপনি একটা জায়গায় হতাশার কথা বলেছেন সেটা হচ্ছে যে আমরা এত ইনভেস্ট করে আসলে কি করব, তাই না, রেসপন্স পাওয়া যাচ্ছে না। তো আমার যেটা ধারণা বা বিশ্বাস এটা তো কেবল আসলে শুরু হয়েছে, যেটা আরো আগে শুরু হলে ভালো হতো, কারণ বাংলাদেশের
রুরাল বা গ্রাম অঞ্চলে বা প্রত্যন্ত অঞ্চলে যে ধরনের কোনো চিকিৎসা ব্যবস্থা নাই বললেই আসলে চলে, কিছু কমিউনিটি ক্লিনিক আছে এবং সেখানে আসলে কোনো স্পেশালাইজড ডাক্তার নাই। তো সেক্ষেত্রে এখানে যে জিনিসটা যে আইসিটি ইনফ্রাস্ট্রাকচার ওই সমস্ত জায়গাগুলোতে আপনাকে যে সুযোগ সুবিধাগুলি আছে সেগুলি আপনাদের প্রোভাইড করতে হবে। যেহেতু আপনি এই ধরনের একটা দায়িত্ব আছেন সেই জন্য বলতেছি। তো ওই ধরনের ইনফ্রাস্ট্রাকচার আসলে বাংলাদেশে এখন পর্যন্ত রেডি আছে কিনা আর কি। আর একটা জায়গায় যেটা দরকার, আমার মনে হয় রুগীরা সবসময় হা হয়ে আছে, তাকিয়ে আছে যে আসলে সরকার কি করতেছে। তো সেক্ষেত্রে একটা বড় জায়গা আছে আসলে এই যে আমি আসলে ই হেলথ বা এই টেলি হেলথ বিষয়টাই আসলে বলতে চাই, কারণ আপনার দপ্তর থেকে টেলি হেলথ বিষয়টাই আসা উচিত, কারণ নট টেলিমেডিসিন, কারণ ওখানে অনেকগুলো বিষয় ফ্যাক্টরগুলো কাজ করবে এবং হেলথ একটা বড় বিষয়। সেক্ষেত্রে আসলে অ্যাওয়ারনেস বিল্ড আপের বিষয়টা, বিশেষ করে আমরা যারা গ্রামে যারা আছে তারা যেটা এক্সপেক্ট করে যে ডাক্তারদের রেসপন্স গুলো বেশি জরুরি, কারণ এখানে আসলে কাজ করতে হবে। সার্জারি বলি বা মেডিসিনের বিষয়গুলি বলি, সবগুলি আসলে প্রোভাইড হয়ে আসবে ডাক্তারদের মাধ্যমে, শুধুমাত্র সবসময় এসএমএস এর মাধ্যমে কিন্তু সম্ভব না। তো সেক্ষেত্রে আসলে গভর্নমেন্টের ইনিশিয়েটিভ কি যে ডাক্তারদের মোটিভেশন করার ব্যাপারে এই টেলিহেলথ কেয়ারের বিষয়ে?
Okay, thank you very much. First of all, I like to say that you should not invest for sophisticated technologies, right, for expanding services to the rural area, because it will require money and at the same time it will not be affordable. That is important. So our health workers, we have got 24,000 community health workers. They have a tablet with internet connection, and if we can actually show the video, right, you'll see that how the health workers are using it for different purposes, not only for collecting data, also for telemedicine and the health education. Second, every community clinic, every union center, we have got laptops with internet, and there are actually multiple uses of the same laptop and the same internet modems. And in the hospitals, we are now actually expanding the networks. So we have the readiness. The second, we need the motivated staffs. This is not so easy, right? We are of course making it, but we have understood that the private practice of the doctors are the main reason. So why the doctors are not that much attentive to their main stations. So we are actually trying to introduce private practice or other kinds of incentive packages so that they work fully in the hospital, not outside. And they will themselves, actually they will not do the private practice anymore. This kind of environment we are thinking or trying to introduce in Bangladesh. You'll see in next 1 to 2 years. Thank you.
Well, thank you, Professor Azad. And every good thing has to come to an end. We had a very nice session in the morning, and we have already consumed our coffee time. Hopefully, there will be some still some residual tea or coffee left. But I think we have spent a very stimulating time, and you have been a lovely audience. I thank all the speakers and the audience. Our friends from Kysushu and Kathmandu have probably left, but Chowdhury is still there. So thank you very much for being with us, and with this we would like to call this session to an end. Thank you very much.
Thank you.
আপনাদের সবার টি অ্যারেঞ্জ করা হয়েছে সিনেট ভবনে, সিনেট ভবনের 3 তলা। লিফট দিয়ে পাশে লিফট আছে, দিয়ে উঠলে গতকালকে যে হলে ছিলেন